Start. Good evening. I am Dr. Karunakar Padi, consultant cardiothoracic and vascular surgeon. Today we are going to do a live endovascular stenting in a case, me and Dr. Dalai. And this is a patient, they have thoracic and abdominal aneurysm, and there is a leak in the chest. So there is almost 2 liters of patient has blood in the chest and came to the hospital in a very serious condition. It is very high risk to take the patient for surgery. So we have decided to go for endovascular stenting because it can be done within 1 hour, and we have Dr. Dalai, who is very expert in endovascular stenting. So we decided to do it in a hybrid way. So both of us are now starting the action. I have exposed the right femoral artery here. So through this we'll put the endovascular stenting, and we are starting the action now.
Namaskaram, good evening. It's a very pleasant evening at Visakhapatnam, and we have come across this case which was having a thoracic aortic aneurysm which is just leaked and contained with 2 liters of hemothorax. A 6th French short sheath has been placed into the femoral artery on the left side, and Bhai means Dr. Karunakar Padi is my brother. So Bhai has exposed the femoral artery, and we will go ahead and show you how to do these procedures. Thank you. There. We will start with a word, take it, and then exchange for pigtails. So to introduce our team, we have Parvati assisting from the endovascular side, and Pari or what? Surgical side. Table, please. Suri is there from the surgical side, and we have Prasad. Prasad, we have Chief Cath Lab Technologist, and we have Gauri. We have Team Anesthesia, Dr. Sujit, and Dr. Akhila from Team Anesthesia. So we have taken our puncture and gone ahead into the ascending aorta. We have confirmed our position. We'll take Ampla super stiff exchange. Meanwhile, Bhai will tell us about the incidence of this disease and why it happens. How do we diagnose aortic aneurysm? Bhai, can you please help?
Yes. This is a very dangerous situation what we have got this patient, because as we know, the aorta, that is carries the blood from the heart to the various organs. Unfortunately, some of the patients, because of atherosclerosis or sometimes marfanoid habitus or sometimes infection, that gets enlarged. So when this enlargement goes above 5 centimeters, there is a risk of spontaneous rupture. For this, around 6.5 centimeters, and the patient was not diagnosed at any time, and luckily that is got contained, and he has reached us, and now we are able to go and treat the disease. Suppose it would not have been contained there, then this type of situation, patient will die on the spot. And even if we delay, that catastrophe can occur. So without any further delay, at this point of the day, now it is almost 9 o'clock night, so we are starting the procedure to save the life of the patient. If this aneurysm comes without rupture, then we can electively go for a surgery or endovascular stenting or a hybrid, as the case may be. But when there is a rupture, patient is sick, there is no time to take the patient for surgery, I think endovascular stenting is a good option to save the life of the patient.
So as we are seeing, the idea will be to seal the thoracic, and sometime we might need an extensive endovascular procedure to really reconstruct the aorta, but we must understand that at this point of time, the most important issue here is to prevent a rebleed of the aneurysm. So idea is to seal the leak and then see whatever has to be done on follow-up. If a further reconstruction is required, that can also be attempted, but don't try to do an extensive procedure in acute setting. Try to seal the rent in the aorta, which is the culprit here.
And the advantage of our unit is we have both the facilities available, surgical facility and endovascular strengthening, and we routinely do this type of surgeries and also endovascular strengthening. So as the case may be, whenever required, 24 hours a day, our full staff is available to handle this crisis, and that is how this situation we are going to handle now.
Right. So we have taken our pigtail to the ascending aorta. We will do an aortogram and understand the anatomy, the radiological anatomy of the aneurysm, and then we will plan for the endovascular graft. Hello? 600 psi 2020. Go Helio. Sir, high up. High down. Table pitch. DMAG, complete DMAG, eye down. Team anesthesia, we will request for apnea. Please be ready. We will request. We will mag taku cheyandi. Full taku. Yeah, excellent. Very good. Table, please. All right. Colmate side to side a bit. Little bit colmation. Yeah. All right. Fine. We are ready. Good to go. Apnea, please. Inject. Perfect. Ventilate. So we can see here the keep ventilating. Stop the image. Lock the table. And eye down. Can I have the screen forward? Yeah. Yeah, good. Bye-bye. Perfect. We can see the irregular. You can take this leg away and get the screen closer to me. So now, Bhai, you can explain about the groin exposure body.
Yes.
Come closer.
So this is the right groin we have exposed, and you can see this is the right femoral artery, and through this we will be pushing a wire, and through that the stent will be deployed, and then we can see the picture.
Light here. So we've taken a 6 of short sheath into the exposed common femoral artery. We do a CT aortogram including up to the proximal SFA. So the measurements are to be decided well ahead, and so that we can plan our graft, and we have to look whether there is some calcium or it's a small artery, then the strategy will be different. So we like to see the course of the graft that's going to travel, whether there's any calcium or anything, so that a lithotripsy or another route can be planned. Water and telling. Contained Chipra, it's not leaking like that we have done in the 7-inch hospitals. Is continuously leaking and we put a graft. Patient shifted from AIMS Bhubaneswar, that case during Rath Yatra. It's not like that. That was transected aorta and which was leaking continuously. Here it is sealed. Probably so. Go ahead. Mag. Table lock and maintain the same. Just the mag. Yeah. So, can I have a Lando Quest super stiff? This one. So these are very stiff systems. So we should have a real good wire across. All right, the Lando Quest. That is seat right? Seat out a hold correct. Yeah, barcode. Right. All right. Out. So, so we are ready with our access. Now we will prepare our graft. Can we have the graft, Sunil? Sunil is with us from Lactec. Today we are using Lactec graft. And we have John Lactec. We have our assistant cardiac surgeon.
I'm opening 30, 26, 200.
We are using a TEVAR graft here today. 30, 26, 200. Yeah, you can show the graph there. All right. So especially when we are deploying a graft in the arch or ascending after a debranching, then we lower the blood pressure to about below 60 or 60 systolic, so the graft is not attacked. And here, because the descending thoracic aorta, we are not so much worried about it. Still, Akhila, can you keep the blood pressure low? Systolic below 80.
Maybe even 5 minutes you put it so that you can see the pressure.
Keep it straight up. So we have to lubricate enough to basically to activate the hydrophilic coating inside and outside. All right. Just a minute. Thank you.
Suction ఉంది ఇక్కడ suction చేయాలి swab give dry mouth heparin given heparin
Give 5,000 heparin.
Just give heparin.
Akhila, how's the systolic blood pressure? Yeah, we have time. We can wait for a couple of minutes.
How much?
No, bring down to 80 systolic.
Sir, suction.
5,000 heparin IV, please. So basically, there are the multiple type of aortic procedure that we do here as a team. Basically, surgically we can debranch. Basically, when the graft is coming in way of major arteries, there's a procedure called debranching, where the arch, the branches from the aortic arch can be surgically, bypassed, and Dr. Padi, our brother, he's like super expert in doing those debranchings. So we do a lot of hybrid procedure where debranching and graftings are required for a type B or type A, sometime dissection, and then Bentel and other procedures are very commonly done with us here. It was given 5,000.
Don't give too much NTG because you don't have direct arterial monitor, no? No, try to manage with gas. What I'm.
Engage the graft.
Suction.
Steadily.
Suction है suction. Okay, cut कर दो ठीक है.
So we'll give a nick. Sorry?
5 o'clock side.
Yeah.
Hydrophilic activation.
Oh, done. Just you can give a nick and we'll go ahead. Just a minute.
No, very good.
Engaged? No.
Engaged. Nice one.
On table.
Okay, done. Okay, done. So just give it away. All right. So Parvati holding the graft nicely. Can I have the skin closer to me? Sunil is occupying the entire space.
8 in the
Sorry.
left side. Rotate towards me. Yes. Perfect. Fix the same position.
Yeah.
Keep going. Some more above. Yes. Hold on there.
Table, please.
Slightly pull back to fix position.
No. We will take a shoot and then we will decide.
Very deep inside. We'll get up to the arch.
We will do that. Table.
Table.
All right. So can we take a small shoot? What's that?
One shoot.
One shot.
Okay. There is
15 ml पर 20 ml कर दो उसको.
25 ml कर दो.
Just we need to mark it. That's all. 20 ml, 15 ml per second, 20 ml. Fantastic. Are you ready? Apnea, please. Inject. Perfect. So थोड़ा सा ऊपर लेना पड़ेगा उसको.
Freeze the image. Lock the table.
Lock the table. Hold it here. No.
This is the aneurysm. So we can
ऊपर लगाओ एक लाइन जहाँ से ग्राफ्ट हम डिप्लॉय करना चालू करेंगे. You want the graft from there?
Lower one may be better.
No. We need at least 2 centimeter of coverage, bhai. Otherwise, we'll have problem. Okay, ventilate.
some more inside. Yes, perfect.
So this will be good. So
Once you deploy 2 waves, we'll take one more.
Subclavian is far above.
Subclavian is here.
far above, yeah. So we take hold with the right hand and just start deploying and maintaining the
Yes, hold there, sir. Slightly pull back the pigtail, please. Pigtail. Hold there, we'll take one more run.
nahi re jalo. No. Lot of contrast will be good.
Go with the rapid. Turn on the trigger. Put it. Low. Yes. Keep going.
Akila, everything holding good? Okay, no problem.
Okay.
We are done.
Show down, please.
Table, please. Okay, perfect.
Right hand. So no scarring.
It is done below diaphragm.
Yes, not
Yeah.
diaphragm.
Yeah,
It's
it's below.
below diaphragm.
Below diaphragm.
Show top, please. Top.
That is what
We want it, yeah.
So now, take
Now
out
we'll deploy the nose curve. So this is how we have to do. Perfect.
Perfect.
We'll recapture. Show me, beta. All right. So we are trying to recapture the nose curve.
Let this come down.
We are bringing it to the straight segment, and
Fully inside.
we are
Done.
done. So now we will take a check shoot, how it looks like,
Then
and
we'll put it inside the top.
then we will see.
Not now.
Table, please. Give me the wire. So tentatively we have just gone through it. So we are trying to take out the pigtail which is in between the graft, table please. In between the graft and the vessel.
Barrage, no?
Yeah.
Stent barrage.
Yeah, outside the stent. Table pitch. So here we will just go inside the graft. Table pitch.
भीतर जाएगी बाहर
Yeah, we will take a one.
ऐसे देख भी व्यस्त है ना
Astanta, but there could be a leak which you might see which is not true because we have a foreign body between the graft and the lumen. So, can I? 20 ml per hour, 20 ml per second. I will request for apnea, table pitch. Mac Toku. All right, apnea, please. Inject. Wow, this is beautiful. Thank God. Chalo. So now we will, yeah, ventilate. Table pitch. How can it's pariya? Bahar kar do.
कलर में प्लान है ये गणेश स्क्रब गणेश
Why though?
ये तो स्क्रब ये काढ़ी ना तो
No, clamp work. So we are done with the procedure and we are trying to close, and I will close the exposure here, and so this is how we have repaired the thoracic aortic aneurysm which was repairing, and our team.
is Dr. Sujit, our
Dr. Sujit is our
cardiac anesthetist. We all team, we have, and this is what is required when there is rupture of the aorta. There is no time for anything, and this is the only way how we can save the patient.
So thank you all for watching. Goodbye and good night from team Dr. Pari and Dr. Dalai with all of us here in Visakhapatnam. See you next time on another case.
Thank you. And